Hello again, and thank you for joining us for the last panel of the morning. It's really my pleasure to have this incorporated into our AHNS meeting this year. I find that when I'm dealing with palliative care issues with my patients, which can become so challenging, the best maneuver I can make is to turn to a professional. And we are very fortunate in the AHNS to have a true professional in palliative care in our midst. And it's my pleasure to introduce Susan McCammon, who is the John W. Poynter Endowed Professor of Otolaryngology and also a professor in the Department of Medicine, as well as Assistant Director of the Gerontology, Geriatrics, and Palliative Care group in the Department of Medicine at the University of Alabama, Birmingham. Susan is also a great leader in the AHNS, serving critical roles on our ethics committee, and now is the secretary of the AHNS, and has done truly stellar work during this very trying time. And Susan has put together a wonderful panel to discuss palliative care and how we as a profession can prepare ourselves for the future. Susan, welcome.
Great. Thank you so much, Dan, and welcome to all my panelists. I'm just thrilled to have the opportunity to bring this group together. I could talk about this, all day. You guys know that about me. So we're going to have a brief introduction and then a roundtable discussion. And I would encourage the audience members to put not only questions, but responses to some of our questions so that we can see how your practice has been evolving. So just a brief introduction to my panelists, and I chose these folks really specifically. Isaac Bohannon is a head and neck surgeon who is pursuing mid-career board eligibility for hospice and palliative medicine, and she's going to tell us a little bit about that. Bridget Fahy was a co-fellow of mine at Sloan Kettering way back. She was in surgical oncology while I was in head and neck, and she is now the University of New Mexico, and she's the program director of the Surgical Oncology Fellowship there. Has done a lot of advocacy for alternate pathways and training for palliative medicine for surgeons. Chris Gourin is at Johns Hopkins University and has had a long interest that she's shared with me in hospice and palliative medicine. She's currently vice chair and physician advisor for quality, safety, and service. And I think she has a lot to offer on quality metrics. Rob Lindau is a head and neck fellowship director in Nebraska. Mark Prince is chair at the Department of Otolaryngology in Michigan and has a long commitment to bioethics and medical humanities. And then I'm really delighted that Nandini Vallath is able to join us from Mumbai today, where it is 9:45 p.m. She is really a leader internationally in specific head and neck fellowship education for palliative care. So welcome to all of them. We have no disclosures. And really, I'm sure all heard me talk about how great palliative care is, and that's not what this is about. We've learned that. We know that palliative care is beneficial to patients, caregivers, and providers. And our Advanced Training Council knows it. We have explicit goals and objectives for palliative care. So now today is really an opportunity to dig in and say, how are our fellows learning and demonstrating these skills? Who is teaching it to them? And how is the best way to coordinate care with specialists in palliative care? Really, the broad fascination, I think, with palliative care, upstream palliative care, began in 2010 with Jennifer Temmel's groundbreaking article on early palliative care for patients with advanced small cell lung cancer in 2010. At that same time, an article came out estimating the current shortage of hospice and palliative physicians to be approximately 10,000 for the need at that time. And 7 years later, ASCO produced a position statement stating that standard of care should be an early palliative care consultation for all patients at the point of diagnosis for stage 3 or stage 4 cancer, which I'm sure where you work is like where I work. That is most of the patients that we see in head and neck. The impact of COVID-19 on all people, all doctors, and all palliative care physicians has been profound. We have all seen more death. The upper right small picture of the poignant refrigerator truck temporary morgues, more isolation, both ourselves and our patients. We've seen delays in cancer treatment. So we are delivering bad news more and more frequently. And often we have isolated patients for whom we're a surrogate family. We have grown and facilitated communication with telehealth, and we have experienced a year in which palliative care specialists have been sheerly overwhelmed. So let's talk about surgeons and hospice and palliative medicine fellowships. And the takeaway point from this is the big blue ball with the tiny green sliver in it, which represents surgeons of all specialties who are board certified through the practice pathway in hospice and palliative medicine, which existed from 2008 to 2012. Since 2013, an ACGME approved fellowship has been required, and I'm going to ask Bridget in a few minutes to talk a little bit about some of the alternatives available to surgeons. This graphic shows the 10 sponsoring boards for hospice and palliative medicine and the requirements for the practice pathway. And looking forward, now that a fellowship is required, you can see the blue line is internal medicine, which is far and away growing. The orange line, family medicine, gray line, pediatrics, and I think we're in maroon right down at the bottom. And I just want to acknowledge my friend and colleague, Anna Berlin, who has been doing this demographic research, which will be published shortly. Let's turn then to think about hospice and palliative medicine and surgical fellowships. So we have an AHNS curriculum, and they have palliative care components, but are we achieving those goals? Are we truly teaching those things? There are ample resources for surgeon-focused modular curriculums, the Harvard curriculum, the EPEC curriculum, which has specialized curricula, including for surgery. The American College of Surgeons has a robust educational program. And today, Nandini Vallath is going to talk to us about Impact HN, which is head and neck fellow-focused modular curriculum in hospice and palliative medicine. And often what we rely on are ad hoc didactics from our institution's hospice and palliative medicine faculty, which are terrific, but often are simply not aware of some of the issues that face surgeons dealing with complex, serious illness. This is just a direct quotation from our AHNS curriculum, and you can see that by the end of the fellowship, the fellows have participated in a minimum number of. And think to yourself, are your fellows really doing this? And if they are, when did they learn how to do it? And who taught them how to do it? And are they doing it well? This is my first attempt at a Wordle, word cloud, and this is taking the entire syllabus for ethics and professionalism, which is where palliative care lives in our curriculum, and illustrating the prominence of palliative care and patient engagement, listening, prognostication. And finally, there's increasing public awareness, which has been made ever more acute and poignant by our experiences with COVID. So now I want to turn to the roundtable discussion portion, and feel free to enter your answers to discussion questions in the Q&A. We welcome your questions, and we'll start with this question. What models of palliative care training have you experienced? None. In my surgical training, early career training in palliative care, or mid-career. And I'm going to turn first to Bridget Fahy and ask you to take a few minutes and just describe what your career path has been like and what you think is important now.
Sure. Thank you so much, Dr. McCammon, for the invitation to participate. So I think that the square in the center really illustrates that I was well off the beaten track when I mentioned to anybody that had trained me in surgery or surgical oncology that I wanted surgical palliative care to be a focus of my practice, both clinically as well as from an academic standpoint. In 2009, a bulletin of the American College of Surgeons came out that was authored in part by this guy, Jeff Dunn. I think I need a tab there, Dr. McCammon.
Yes.
About the pathways for surgeons into the world of palliative medicine. And so it really started off pretty ad hoc. That was me literally cold calling Dr. Dunn and saying, hey, I'm interested. And then being brought into the fold of the American College of Surgeons Committee on Surgical Palliative Care, for which now Ann Mosenthal, who's a trauma critical care surgeon, is the chair lead of that. And, first of all, I found sort of a warm and welcoming place that I wasn't insane, that this was actually a viable academic outlet for myself, and that it was important. And I think for those that don't know, Dr. Dunn received the HPM Lifetime Achievement Award, which was richly deserved, but it was hard not to be around Jeff in that time and really feel like you were going to church hearing about this. So I went forward and I was part of that experiential pathway that Dr. McCammon described. And you can see there, I was certificate 48 from the American Board of Surgery. And that I was boarded in 2012. And, you know, at that time, I was also an associate program director for general surgery, clearly saw that this was not getting incorporated into the general surgery residency, and was sympathetic, you know, as an associate program director. 5 years of general surgery or 6 of otolaryngology sounds like a long time, but boy, it goes by quickly. And trying to cram in, because this is what it was felt like, one more kind of soft topic into surgical training was not anybody's priority. And so I went on a little mission, and poor Frank Lewis at the time, I'm sure, who wanted to block me in emails, I said, Dr. Lewis, who is the president of the American Board of Surgery, I said, we have to have a mechanism for surgery residents to be able to get trained that want to do this. We have to be able to legitimize training in palliative medicine for surgeons. And so what I've highlighted for you there is that starting in July of 2015, in fact, our surgery residents can come in and do a hospice and palliative medicine fellowship basically during their training. In general surgery, it's not uncommon for those that are fellowship bound to take 2 years out, quote, in the lab, and that the definition of what constitutes in the lab is really morphed, but including being able to do that hospice and palliative medicine fellowship. And so really trying to create a way for residents to consider this as part of their career. And, you know, for the surgeons in the room, as which I am, of course, one, no surgery resident wants to spend all this time getting surgical training and then take off for a non-operative year. And this was already something that was sort of well baked into the American Board of Surgery, that we have critical care fellowships that they're able to do, burn fellowships that are also largely non-procedural fellowships. So anyway, I would say if I have made any contribution, I'm pretty proud of the fact that this pathway is open and is being increasingly tapped into by surgical residents. Of course, they can't be boarded in hospice and palliative medicine until they've received their primary board certification first. So there's some logistics about when do you take the test and so forth for the board certification. So, and then I'll maybe speak just very briefly in my role as a program director for a complex general surgical oncology fellowship. We, like you, have, you know, defined requirements about exposure to palliative care. I think the words continue to be getting a little more discrete and a little less nebulous in terms of what is exposure. But even now, I think there are maybe 1 or 2 surgical oncology fellowships that actually have a required palliative medicine rotation. So I'm happy to talk about that more.
Thank you, Bridget. I don't see my slides anymore, but it says I'm still screen sharing. Can you see my slides?
We can.
You can? Oh, good.
Yes.
Well, that's a minor miracle. All right. Thank you, Bridget. Panicking over here. So I'm going to move next to Isaac Bohannon, a head and neck surgeon in Washington, and ask you to talk a little bit about your mid-career shift.
Thanks so much. So I think I work for Kaiser Permanente here in Seattle and Bellevue, Washington, and have long thought about palliative care, and similar to Bridget, didn't really know that this was an outlet until I went to the Surgical Palliative Care Symposium at the ACS meeting in 2019, and I felt like, just like you said, I was among my people, and that's thanks to Susan's introduction. But I decided to embark on a mid-career training process after doing things like Vital Talk and trying to learn about communication sort of on my own, you know, in actual practice. That didn't feel like it was enough for me. And I have enrolled in and am in the middle of a master's in palliative care through the University of Colorado at Denver. And this is a dovetailed program that lets me complete the didactics that would be required for taking that year away from otolaryngology practice, together with a unique ACGME approved program that lets me do clinical palliative care in my community or in Kaiser, with the plan to be board eligible for hospice and palliative medicine certification in the future once I complete that training. And so a lot of the things that Bridget's mentioned, that I didn't want to leave my practice. I didn't want to leave Kaiser. I didn't want to leave my surgical skills even for a year. This is, I think, a really unique opportunity for folks who are mid-career, maybe not necessarily in an academic setting, which I'm not, to pursue the additional formal training that lets me bridge this gap, and then I hope in the future to practice care in both avenues. Yeah, so I did include some resources in my uploaded stuff, just in terms of like links to consider, and books that have helped me kind of along this journey personally. But I think most importantly, just for folks that aren't or are thinking about this for themselves, connect with who you are and who also does this kind of work, and then reach out and explore what might work for you. So thank you.
Thank you. Thank you so much. And we, again, welcome questions from the audience about how this has worked for these practitioners. And now we're going to move on. Move on to more general questions about how this has been taught in the past and currently. And I'd like to start with Mark Prince, who's been practicing for many years. How did you learn what we think of as core palliative care skills in your training? Unmute.
Thank you. Yeah, thank you, Susan. Yeah, so I did type a little thing into the chat. I just hadn't entered it, but when you'd ask is about the discussion question. So I think one thing that many of you may not know about me, which is kind of a little bit of a workaround to this question, is I actually was a primary care physician before I went back and did an otolaryngology residency. So I will tell you that I probably had more exposure to palliative care and kind of hospice care and training and education in that area as a result of that kind of strange background. But to speak specifically to, me as a head and neck surgeon, I think things are much better. When I did my fellowship, which is quite a number of years ago now, certainly there was no specific training related to palliative care or hospice care at all, not that I recall. It was discussed sometimes sort of maybe more pointedly or vaguely around specific cases that were ongoing, and so there was some learning in that way. I think that my biggest exposure to palliative care actually, though, occurred post-training, and really was driven by a personal interest in it, but also actually by being surrounded by a really great palliative care and hospice team at the VA that were more integrally part of the head and neck cancer care that was provided at the VA that I continue to work at. And so it was really ad hoc, driven to some extent by personal interest and a recognition of the need for this, but perhaps enhanced by my primary care background.
Thank you. I did not know that. Chris, maybe you can tell us a little bit about what your experience was like coming through ENT and head and neck training.
Thank you. Well, I've had no formal palliative care training, but in 21 years of practice, I've increasingly developed a growing interest in it because, as head and neck cancer surgeons, we lose a proportion of our patients. And increasingly in the last 20 years, we do a greater proportion of salvage surgery, which is often palliative and associated with poorer outcomes. So by definition, but the nature of our specialty means that we are going to come in increasing contact with patients who have poorer prognosis and poorer outcomes. And I have been impressed with the palliative care providers that I've encountered. We're fortunate at Hopkins to have some of the leaders like Tom Smith here. I have not had any formal palliative care training. It's just increasingly been through interaction. And as you and I have talked about, I have sought ways of formally training in palliative care. And it is a challenge. There's no question once we are in established practice, because the training has to be subsidized in some way, either by ourselves or by our institutions, because it comes at a cost. There are downstream benefits to palliative care, and we all know this, right? Palliative care increases the probability of a good outcome, meaning fewer heroic surgeries with poor outcomes will be performed when patients have a good understanding of what their goals of care are and what are realistic goals of the care that we, options that we recommend to patients. In addition, we know that early integration of palliative care reduces hospitalization, length of stay, it reduces emergency room visits, it reduces readmissions, and it reduces in-hospital mortality. And not only does this have, pure quality improvement outcome metrics that we can see, but there are downstream costs to the hospital. And ultimately, it's just the right thing to do. But is our training sufficient? I would argue it's not. And so a panel like this is so important, because we need to address the goals that we state in our fellowship training statement, because I don't believe most programs are meeting this right now.
I won't tell you who wrote the goals in the curriculum. Might have been me. And finally, Rob, as a fellowship director, what are your thoughts about your training and about how we're delivering this to our current fellows?
Thank you for giving me the opportunity to be on this panel. I truly appreciate it. I went to medical school at the Medical College of Wisconsin, and they were very good about exposing the medical students to palliative care. And it's been a while since I've been in medical school, but I want to say that we had to spend 2 weeks on palliative care as a medical student, as a third-year medical student, and having that as integral part of our training. I then did general surgery residency, and we did not have one palliative care provider at my institution my entire five-year residency. Even coming into practice after doing a head and neck fellowship and starting my practice, it was we had inpatient palliative care, mostly was seen as a hospice care providers. Now we have integrated in our practice here outpatient palliative care, and trying to incorporate that into fellowship education, not only using the curriculum, I think is vitally important from the reading perspective, but I view it as a scapular flap. We don't do a lot of scapular free flaps. So when we're having these discussions with patients and their patients and the families, these are must opportunities for the fellows to be at. Much like that scapular free flap, that the 5 that we do a year at our institution, you better be there to learn how to do that scapular free flap. Same with these patient care conferences. It's a must be for the fellow to be at, and trying to incorporate that because it shows that as a priority. So if the staff and the faculty do not view palliative care and hospice care as a priority for their patients, you can never teach a fellow that. So we can put it in the curriculum all that we want, but until we start changing the minds of the practicing physicians towards and their ideas towards palliative care and hospice care, we're never going to be able to affect the fellow education. And so that's what we've been doing, and and incorporating palliative care into our teams, coming to our tumor conference, trying to build a survivorship clinic where we get palliative care on board early on the majority of our patients. We did a combined geriatric head and neck program, which was very successful, where she would round on all our patients. So just trying to buy in, get the staff buy-in, and then I think we get the fellow buy-in after that.
Thank you. I love that analogy of the scapula flap, because time pressures really are huge in incorporating this. I find, if anybody should, I should be able to make sure my fellow gets all of this, and it's the time pressures are very hard. And then I think you're right about role modeling. I think that if it's something that you outsource to someone else, all the time. Your students and your fellows and your patients will pick up on it. So, so the part that we do, we need to do excellently well. And that's a good segue to my next question, which is, what would ideal training in palliative care look like for your learners? Would it be at the department level, institution level, or in this era of Zoom education, which we have a panel on later this afternoon, at a national or international level? And I'm just thrilled to have Dr. Vallath here to talk about her Impact HN curriculum for head and neck fellows. Please unmute yourself.
Thank you, Susan. I'm very happy to be here. So I'll just continue based on what Dr. Lindau mentioned about how it's important to have a receptive institutional culture before we have the fellows having exposure to palliative care modules. So when this inquiry about possibility of starting integrating the palliative care modules into the fellowship training of head and neck trainees came to us, means the palliative care community in the National Cancer Grid of India. The first thing that we did was to have several meetings with the center directors of the institution to understand the receptivity and the ideas that they had about palliative care, and how much they are engaged or they are committed to. Because otherwise, even if we have modules, it will totally be contradictory to what things are being practiced in the center. So this was one of the earliest things that we did. And I don't know how to answer the specific question of departmental, institution, or national level, because we are doing an online training. The centers are spread across India. And the pattern that we have used is 9 role plays around which the modules have been developed. So there are 2 patients, one in the curative stage, who go through about 3 or 4 role plays, and across until the surgery is over, and then there is a survivorship issue being discussed, etc. And a second patient who goes through several role plays till the patient dies, and then there is a bereavement and etc. So we are using these role plays just like we thought it may be best to learn like how we learned as residents. And so to get a patient with multiple issues together, the fears and concerns, so that the discussions and communications come up, shared decision making come up, symptoms are there. So how to handle the mild pain initially, then as the pain increases, how to change your medications, and other symptoms that come in post-op, which are, to differentiate the patients who are actually having no cancer, but still having the fear of recurrence, etc. So we try to create the theme of each module around the role play, and even include the evaluation based on these discussions. And this is the online part of it, where the fellows are doing on their own. After that, we are having monthly sessions, which is live, and where we pick the threads up and create active discussions on these must-know topics of those modules. And so there are these 2 phases, where there are online modules, as well as the live sessions, where there is a panel and the fellows attend, and they are asking questions or answering questions. And we are also lacing it with several interesting quiz. And I have just shared something with Susan, if you can show, I don't know. So this is like a edutainment corner in the modular page. Susan, yeah. So this is something that the fellows have access to. So, trying to make them think, and so they have to post a comment, and we have created this owl, that is like, because we call our program as Impact HN. So whoever gives the wittiest comment here will get extra marks, etc. And there is a fellows corner where they themselves can choose some links and some quotes or some experiences they have had from the training. So they have a free access to posting things based on what they are learning from the Impact HN modules. Besides this, online as well as live sessions, which are happening monthly, we have made them groups. We have grouped them into 6 or 7 per a panel of palliative care faculty. And we have these smaller sessions where they bring in their own, which happens, not more than once or twice per month, which are between these live sessions, and they bring in their own actual case stories, and not necessarily like a teleconsultation, but general questions about this is something that we face often. So how do we proceed? So sometimes we have even had small role plays during those cases based on the story that they talk about. So we are quite excited creating these different aspects of the learning. The feedback has been good. And I think I'll stop here and let Susan ask any more specific questions.
Sure. I'd like to take a moment to open it up to the rest of the panelists for any questions they might have for Dr. Vallath. Top of my list is, when is this coming to our fellowships, a fellowship near us?
I mean, when you shift to India, maybe. This is currently open to the National Cancer Grid members of India, and both the associations in India. One is the Association of Oromaxillofacial Surgeons of India, and the other is the Foundation for Head and Neck Oncology. So both of them have been fully engaged, and we have created 3 groups of people who are doctors who can access this program. One is the fellowship mode. The other are the observers, so who have access to everything they can see, but there is no commitment. They don't have to pass or fail, or there are no credits, there are no marks, but they can just go through the modules. And we have also created a TOT model, that is the training of trainers, because we know that we cannot hold on to this for long. We are a small community. And the very reason that this was created is because India head and neck cancer is huge, and mostly 67% of them come late. And so it's a huge requirement. And also when we look at integration of palliative care, we have that those waves going through where the palliative care input is small in the beginning, and then it keeps on growing as the disease advances. Whereas in head and neck cancer, we can begin with a much larger wave because patient presents with high amount of symptoms, complex issues, image issues, and so right from the beginning, right from the contact to the healthcare system, there is so much of palliative care need to be done. And that is why probably the surgical community reached out, and they're really, they're keen on integrating. So we are creating this TOT set of professionals who will take on this whole course and carry it for long term, because this has to be finally held by the head and neck surgical community. And we are just there in the first 2 years to build it and, leave it to the community to take it on.
Thank you, Nandini, so much. And I think that we've experienced such a growth in international online education that I feel that within the next couple of years, we may be able to incorporate this or something like this into our training to complement our role modeling. In the interest of time, I'm going to go to the next question, I think. So how do you demonstrate the value of palliative care to your department or institution? I'd like Chris to take the first stab at that. And then what is the best way to ensure standard training and care? And Bridget, I'm going to ask you to talk about that in terms of incorporating it into ACGME requirements and into the board exam format. So Chris?
Boy, that's a broad question. There are, well, from an institutional standpoint, there's no question that palliative care provides value and meaning to healthcare systems. And so there is an online site called the Center to Advance Palliative Care that has some really nice online modules people can take, and also some documents that show the value of palliative care to institutions, and they have metrics. So the provision of palliative care results in a 48% reduction in readmissions, a 28% reduction in the cost per day for patients who are admitted with advanced illnesses of all types who receive palliative care, a 50% reduction in admissions for patients with advanced illness, 35% reduction in ER visits, 43% reduction in hospital to hospital transfers from ERs, and 36% reduction in total costs. When you look at mortality metrics, these are most profound for cancer patients. But again, patients with advanced cancers who undergo surgery, and I guess that's what we're interested in specifically for this panel, surgical patients who patients undergoing advanced, often palliative operations, have a much higher morbidity and mortality. And so inpatient mortality is a metric that not only the department values, but the institution values. And so when there's an increased mortality for a particular operation, the provision of palliative care often can set the tone, particularly when it's administered before the admission, in setting realistic goals and expectations of treatment that might make patients and surgeons explore different options. From inpatient mortality, in a purely mercenary standpoint, this affects institutional metrics and standing. And so patients who are admitted in advanced stages of disease who die in the hospital impact hospital standing. Now at our institution, one thing that we've noticed in the last year is that a lot of patients whose deaths have been attributed to a particular service, and our service specifically, are patients whose admission resulted in an inpatient palliative care consult and subsequently the decision to transition to hospice care. But we do not have an inpatient palliative care unit. And the reason that we don't is that our institution has not allowed advanced practice nurses to serve as primary palliative care providers for inpatients. So if you wanted to transition a patient to the palliative care team, only a physician can be the accepting provider. And we have a palliative care crisis. Providers burn out. There's just not enough of them. And so our institution closed the inpatient palliative care unit. And what we found is that there are a number of mortalities that have been attributed to services for patients who were on hospice care, but hadn't left the hospital in time. So there's been a lot of increased attention recently to the value of palliative care, just from that purely mercenary standpoint of what is due to our mortality statistics. But in terms of the value of palliative care, other metrics like length of stay, readmissions, hospital to hospital or ER to ER transfers, and mortality and morbidity after palliative operations, there's a clear benefit, and it's well demonstrated in the literature. From a departmental standing, many people may not know that departments get individual surgeon metrics that we look at. And, you look at them and you risk adjust them. You say, well, this patient was very ill, or that patient you could have predicted would have a long length of stay and an increased complication rate based on how they presented. These are the patients who palliative care could impact their treatment. But again, I'm not sure we all do such a great job of what ASCO mandates, which is the integration of palliative care services within 8 weeks of starting treatment for all patients with advanced cancer. That's the gold standard, and how many of us actually provide that?
Thank you. That really powerful statistics. And I think, we've probably all experienced this, that we appreciate the qualitative aspects of palliative care, but making the quantitative arguments often feels uncomfortable. But I would really encourage you to look at the CAPC website, because they have provided really well presented packaged data that you can use to make your case to the department and the institution. Bridget, what about ensuring standard training and care? We say it's important. We say we're going to do it. We think we're doing it. How do we know?
So I think there are a couple of ways. One is trying to think that we're all going to carve out and send our residents / fellows onto a palliative care rotation may not be feasible from either the training requirement timeline standpoint, or even the resources and availability of our palliative care team. I know our palliative care team is reached out to by many departments and levels of trainees to go on service, and so that can be difficult. So I think that one way to do that is that palliative care rounds get incorporated into regular work rounds. So I know I have a fortunately very supportive general surgery program director who is planning on having that be a part of multidisciplinary rounds in the ICU. And I think part of that just normalizes it. So we get away from that. There's nothing left to do, let's call palliative care mode. and where we are starting to sort of screen, if you will, those patients and their families for palliative care needs kind of in real time. And it gets incorporated into the regular work of care, not just what insurance do they have and what SNF, does their insurance cover at discharge, but really what are their needs. And then I think it goes back to what we were just talking about in terms of length of stay. And there may be some other little goodies that the institution will like that come out as a result, a byproduct, maybe unintentional, of good quality care. And then I'll just say briefly, my current role is as the committee chair for basically the oral board examination for complex general and surgical oncology. So nobody gets board certified in complex general surgical oncology without getting a palliative care oral exam question. They also are seeing these questions on their written exams as well. And I'm very grateful to the American Board of Surgery to see that this is actually of value. And I think if anybody's learned anything, it's probably the examiners as much as the examinees, because now my co-examiners are like, what do you do with that again? And oh my God, I learned so much in that question. Oh, you mean that hydromorphone's more potent than Vicodin? How did that happen? It's that kind of stuff. So I think that sometimes the learning is unintentional, but still obviously quite valuable.
Thank you. We are just about out of time, so I am going to skip to our last question, and I'm going to ask Mark and Rob to start out with this and then open it up to everybody to think about what obstacles have you experienced in teaching or delivering palliative care as a head and neck surgeon.
Yeah, maybe I'll just say very quickly, I think we only have about 2 minutes, but I'll give it from a chair's perspective, something we haven't really heard, which is, we've heard why we should support palliative care as part of our departments, part of our institutions. So I think that's pretty obvious, I hope, at this point to all of us. The real question is, how do we support it? And I think we've seen a couple of examples of how this can occur within our training programs, and we should extend it obviously through residency as well as fellowships. But I think we learned about one model where somebody in mid-career may actually be able to do some kind of a fellowship. I think it's really important that leadership make these type of opportunities available. They cost something, but the payback or the return on the investment for patients, for our educational programs, and actually also programmatically are immense. And so worthwhile investing in as a department and an institution.
Thank you. Rob, any closing comments?
When you're talking about the obstacles, the biggest obstacle, is time for the fellow. They're so pulled in multiple different directions, ablative side, reconstructive side, endocrine, and really seeing palliative care and these discussions and these patient interactions has to be seen as part of our multidisciplinary care. You talked a little bit about abandonment. You put that slide about abandonment up right now too. We as surgeons, when we deal with head and neck, and we see ourselves as the primary care provider for our patients, and when we send them to chemoradiation and non-surgical care, we don't see that as abandonment. The same aspect I think has to be done with palliative care, is seeing our palliative care providers and our palliative care colleagues as part of the team, and part of our multidisciplinary care. We expect our fellows to spend time with rad-onc and med-onc, dental oncology, but we need to really focus on having them spend time in palliative care and having that expectation of seeing them as our multidisciplinary team as well.
Thank you. And we are indeed at the end of our time. So I just close with my slide of quotations about non-abandonment as a core value, and thank my panelists for joining me. And I hope that we continue this conversation. Thank you, Dan.
Thank you so much.
Thank you so much.
Susan and everyone on the panel, thank you so much for your sharing of your experiences and your thoughtfulness. And Mark, I think you point out a major thing. This needs to be valued at the highest level. And as we look at trainees, I think what was pointed out is kind of like children, they will value what they see. And on a day-to-day basis, we value as much as how this patient is going to do when they leave the hospital as to how their micro looks when they leave the OR. And every aspect of that, that's the most powerful thing we can do. And I think you all exemplified that beautifully. And we thank you very much. And so to all the people watching, we'll take a break now for lunch, and we'll see you back in an hour. Take a little moment to look at the exhibits that are on the COSM platform, and we'll have a phenomenal set of panels led by Melanie in the afternoon. So thank you all very much.
Thank you.